inflammation of the vessel wall, right? So what happens when there is vasculitis? The vessel wall is inflamed, it becomes weak, right? Then what can happen? It can leak blood into the tissues, right? The weakened wall can leak blood into the tissues. And this is classically represented by the very typical symptom and sign of vasculitis, which is called as palpable purpura. When vasculitis occurs in the blood vessels, superficial blood vessels beneath the skin, then what happens? The weakened vessels leak blood into the tissues, and there is purpura that is raised, right? Generally, when we see purpura in diseases of the blood, for example, in let's say thrombocytopenia, we know is deficiency of platelets, right? And due to deficiency of platelets, there is also purpura, that is hemorrhage beneath the skin, or blood beneath the skin. Now that purpura is not palpable, right? That is, it is not raised. If you feel it with the finger, then the skin surface is smooth, right? With closing your eyes, you cannot appreciate that there is something, right? On the other hand, the purpura of vasculitis is palpable, that is, it is raised, right, from the skin surface, right? Similarly, what else can happen? A vessel which is inflamed, it can lead to thrombosis. And we have discussed in atherosclerosis that in atherosclerosis, what happens is plaque formation, tiny plaque formation that ruptures and the thrombosis occurs in the vessel, which leads to ischemic infarction. Right? Similarly, in vasculitis, what happens? The vasculitis phenomena damages the endothelium, right? And so thrombosis or blood clot formed in the blood vessel, therefore there is ischemia and there is ischemic infarction, right? Third thing that which can happen in vasculitis is the weakened vessel can form aneurysm. The same thing as we have learned in atherosclerotic disease, that atherosclerosis or hypertension can also weaken the vessel and lead to formation of an aneurysm, right? So all those things can happen in vasculitis, that is hemorrhage, right? Then aneurysm formation and thrombosis. And obviously the signs and symptoms depend upon what is happening out there and where, in which organ system it occurs, right? Vasculitis occurs in anywhere along the body, right? It can occur in the blood vessels beneath the skin. It can occur in the upper respiratory tract. It can occur in lower respiratory tract. It can occur in GI tract. It can occur, in kidneys, in parenchymal organs, anywhere vasculitis can occur. It is a very important disease to know and understand. Okay, so as the name is telling you, vasculitis is vessel wall inflammation, right? And you know that we characterize the vessels into arteries and veins, and then we characterize arteries into large or elastic arteries, then medium size or muscular arteries, and then small size arteries. So similarly, we will categorize or classify vasculitis into large vessel vasculitis, right? Then medium vessel vasculitis, and then small vessel vasculitis. Okay, what causes vasculitis? Vasculitis, there are two main causes of vasculitis. One and most important cause is immune mediated, right? That is, most of the vasculitis are immune mediated, right? That is, our own immune cells become self-reactive. Some kind of antibodies are formed in the circulation, then that will go and somehow damage the vessel wall, right? The second most important cause is infection. It can be viral infection, it can be fungal infection, it can be bacterial infection. For example, in disseminated meningococemia, meningococcal infection, which causes meningitis. Sometimes it causes disseminated meningococemia, in which widespread vasculitis occurs due to meningococcal organism. Similarly, in disseminated gonococcal infection, there is widespread infection by gonococcal organisms, and same vasculitis can occur, right? The less common causes or less important causes may be chemical injury, physical injury, but you need to remember these two important causes: infection and immune mediated. Okay, so as I told you that pathogenesis of vasculitis, infectious, number one, and number two, immune mediated inflammation, right? Okay, and we characterize or classify vasculitis on the basis of vessel size of the vessel involved, that is small vessel vasculitis, medium vessel vasculitis, and then large vessel vasculitis. Okay, so this is a very beautiful diagram which is covering almost all the aspects of vasculitis, right? And here you can see that vasculitis are being divided into number one, these large vessel vasculitis, right? And these include two vasculitis, which are number one, temporal arthritis, which is also called as giant cell arthritis, and number two is Takayasu arthritis, right? So these two uh, vasculitis are classified under the category of large vessel vasculitis, right? Then we have medium vessel vasculitis, and here again we have two diseases which come under the category of medium vessel vasculitis. One is polyarthritis nodosa, and the second one is Kawasaki disease. And then we have a small vessel vasculitis, and here we have three vasculitis which are ANCA associated, right? ANCA means anti-neutrophil cytoplasmic antibodies, and we will discuss this in detail. And which are number one, microscopic polyangiitis. The second is Wagner's granulomatosis, which is called as granulomatosis and angiitis. And third one is Shrug-Strauss syndrome, right? And then we have vasculitis which is associated with SLE, then Knox-Schonlein purpura or IgA associated vasculitis, and cryoglobulinemia. Okay, so if you see this picture is also telling you something about morphology and pathogenesis. For example, if we see the category of a small vessel vasculitis, then here it has divided the small vessel vasculitis into two major categories based on pathogenesis. That is vasculitis which are caused by immune complexes. Immune complexes, we know this is a type 3 hypersensitivity response. And in type 3 hypersensitivity response, what happens that antigen and antibody, it makes immune complexes. Once an immune complex is formed, it can recruit inflammatory cell, it can activate the complement end products, they can recruit neutrophils, neutrophils will release the enzyme and ultimately causes end organ damage, and here the end organ is vessel, right? So SLE, in SLE what happens, the ultraviolet light damages the skin cell. The skin cell releases the DNA and its substances, right, which act as antigens. Antibodies are formed against that skin cell DNA, and so antigen antibody complexes are formed. They get deposited in the vessels, and so the complement is activated and damage occurs, right? In Knox-Schonlein purpura, what happens that IgA immune complexes are formed which are formed by IgA, right? IgA immune complexes are formed, and then it typically occurs after an upper respiratory tract infection. After upper respiratory tract infection, what happens that antibodies, IgA antibodies are formed, right? Against the pathogens, and then it forms immune complexes, and it causes, it also causes a renal disease, which is called as IgA nephropathy, and it causes a vasculitis, which is called as Knox-Schonlein purpura. Similarly, in cryoglobulinemia, the immune complex mediated vasculitis occurs, right? Okay. On the other hand, good posture syndrome is not immune complex mediated, basically an antibody mediated. Okay. So then the second category is which is quasi-immune, that is no immune complexes. Then what is the pathogenesis? The pathogenesis is anti-neutrophil cytoplasmic antibody, right? So anti-neutrophils cytoplasmic antibodies are formed, and as the name is telling you, anti-neutrophils. So these antibodies are against the neutrophils, right? So these antibodies attack the neutrophils. The neutrophils releases its enzymes, and those enzymes, causes damage to the endothelium and vessel wall, right? So here again, the first category is shrug-spot syndrome. Now it is telling you that in shrug-spot syndrome, the eosinophilia, asthma, and granulomas. That is, if you do a blood test, there would be increased eosinophilic count, right? And clinically, the patient will have allergic rhinitis and asthma, and in asthma there is increased eosinophils as well. So by this connection, you can easily remember eosinophilia and asthma. And then if you biopsy the vessel or biopsy skin tissue to see there would be granulomas inside the vessel wall, right? So the typical triad of eosinophilia, asthma, and granulomas is shrug-spot syndrome, right? Or you can see the granulomatous vasculitis with asthma and eosinophilia. And asthma and eosinophilia is only seen in this type of vasculitis. So this is a unique vasculitis which is ANCA-associated, and specifically this is P-ANCA, right? And we will see what are the different types of ANCA. So this is shrug-spot syndrome. So if we remove asthma and eosinophilia, then only granulomas is there, and typically in venous granulomatosis, there is a confluent necrosis. Confluent necrosis along with granulomas, and this is called as granulomatosis and angiitis. Previously called as venous granulomatosis, still it's a common name. So you should remember both the names, granulomatosis and angiitis or venous granulomatosis, right? This is again an ANCA-associated vasculitis, and I told you what is ANCA, and here they are C-ANCA, right? So there is no eosinophilia, there is no asthma, but there are granulomas. And here in third category of ANCA-associated vasculitis, there is no granuloma, there is no asthma, and there is no eosinophilia. And this is microscopic polyangiitis. So there would be vasculitis, that is inflammation of the blood vessels wall, that is inflammatory cells will be present in the blood vessel wall, and it can have palpable purpura, etc., depending upon which organ is involved, right? But there would be no asthma and there would be no granulomas, right? So this is a summary of a small vessel vasculitis, right? And one thing about venous granulomatosis or granulomatosis and angiitis is that granulomatosis and angiitis, there is a typical triad of three of granulomatous vasculitis. Number one. The second is involvement of upper respiratory tract, then involvement of lower respiratory tract, and involvement of kidney. So along with the granulomatous vasculitis or necrotizing vasculitis, to be precise and a better term for it, then there are triad of three organ involvement: upper respiratory tract, lower respiratory tract, and kidney. So if in the clinical scenario, the patient has a history of recurrent upper respiratory tract infection, history of recurrent pneumonias, and the patient may have a history of renal disease or raised creatinine or hematuria, right? And then the ANCA is positive, so this is probably granulomatosis and angiitis, right? For the clinical scenario tells you that there is necrotizing or granulomatous vasculitis. Okay. Okay. So this is the summary of the small vessel vasculitis. Now we come to medium vessel vasculitis. In medium vessel vasculitis, a polyarthritis nodosa is immune complex mediated, right? And the thing which you need to know about polyarthritis nodosa is that polyarthritis nodosa do not involve the lung, right? Apart from lung, it can involve any other organ system. It can involve the kidney, it can involve the skin, any other GIT, any other organ system is involved, and therefore the sign and symptom depend upon which organ is involved. If kidney is involved, there will be obviously hematuria, there will be raised creatinine, and so on. If GIT is involved, there will be diarrhea, there would be blood in the stool, etc. Right? And it is immune complex mediated, right? Then Kawasaki disease, it generally occurs in children. Its pathogenesis is in anti-endothelial cell antibodies. So now another pathogenesis comes into play. Up till now, we have seen immune complex mediated, anti-associated, and now the third pathogenesis is anti-endothelial cell antibodies. And now the name is telling you these antibodies are against the endothelial cells. So obviously they damage the endothelial cells, and it causes the disease manifestation, right? And we will discuss in detail the Kawasaki disease, but it is also called as hand, foot, and mouth disease. And the name is telling you it affects the hand, it affects the feet, and it affects the oral cavity or perioral areas. So there is ulceration and erythema, redness around the lips, in the or inside the mouth. For example, the tongue becomes enlarged and glossy and red. There would be ulceration of hands and feet and edema of the hands and feet. And the thing to worry is that Kawasaki disease, coronary artery can be involved, and there can be coronary thrombosis and myocardial infarction, right? So myocardial infarction do not occur in children. It do not occur. It will not occur in a patient who is 10 years or 15 years old. But if coronary artery thrombosis and myocardial infarction is occurring in such age, we should think of Kawasaki disease, right? So this is a very important cause of myocardial infarction or coronary artery thrombosis in children and young individuals, right? Okay, then large vessel vasculitis. And large vessel vasculitis, as I told you, we have two categories. One is temporal arteritis, and the second one is Takayasu arteritis, right? And both are granulomatous, that is on morphology. There would be granulomatous inflammation, that is granulomas will be formed inside the blood vessel wall, right? So we will discuss these two categories in detail. In temporal arteritis, the typical symptom is headache, right? So there is headache which is very severe, number one. Number two, there would be polymyalgia rheumatica. Polymyalgia rheumatica means symptoms similar to what we see in rheumatic diseases. That is, there would be joint pain. And then there would be fever and systemic symptoms. So fever, systemic symptoms, joint pain, headache, jaw claudication. That is, the patient will say that when I chew during, chew, then what happens? There is pain in the jaw. It's called as jaw claudication, right? Then another very typical symptom is that the temporal artery, which runs here on the forehead, it becomes it becomes palpable, and there will be pain on palpation, right? So there is pain and palpation of the temporal artery. What tests to do next would be ESR. ESR would be raised, and then you can start the treatment with corticosteroids, or you can do a temporal artery biopsy. So this was temporal arteritis or giant cell arteritis. And then the second one is Takayasu arteritis. This typically occurs in young females of Asian descent, and it affects the arteries sorry, which are emerging from the arch of the aorta, right? And these arteries are supplying the blood to the upper limbs. So there would be loss, there would be decreased blood supply to the upper limbs, and so it is also called as pulseless disease, right? Pulseless disease. That is, if the clinician try to take the pulse, it is very difficult to locate the pulse because there is very little flow in the blood vessels supplying to the upper limb, right? The common complication of these two diseases, that is Takayasu arteritis and giant cell arteritis or temporal arteritis, is that they both can involve the ophthalmic arteries, and therefore it can lead to blindness, right? So this is a complication of these two, arthritis, right? And so prompt treatment is necessary. And in general, as you know, these are autoimmune diseases. So obviously, I will not go into to discuss the treatment, but in general, whenever you are treating an autoimmune disease, then the treatment options you have is corticosteroids. If it does not respond to corticosteroids, then cytotoxic drugs can be tried, or IV immunoglobulins. So IV immunoglobulins, cytotoxic drugs, and corticosteroids are given to treat these diseases, because as we have seen, most of them are immune mediated, right? So as I told you, the pathogenesis of vasculitis: number one, infectious; number two, non-infectious. And non-infectious, we have discussed immune complex mediated anti-neutrophil cytoplasmic antibodies and anti-endothelial antibodies. T cells may be involved in some of the diseases, or it may be part of the pathogenesis in many vasculitis. It is not the sole cause. Okay, so as I told you, in immune complex, for example, the prototype immune complex mediated vasculitis is polyarthritis nodosa, or the SLE associated vasculitis. So what happens in, for example, SLE, as I told you, the sunlight damages, ultraviolet light damages the skin cells release the DNA, right? Against that DNA, antibodies are formed. The anti-DNA antibodies, they form complexes with the DNA, and so what happens is immune complexes are deposited in the vessel wall, and it activates the complement and it recruits the neutrophil, right? So here again, you can see these are the immune complexes which are adhered to the vessel wall, and here you can see it activated the complement system, and therefore neutrophils are recruited, the neutrophil release the enzyme, and these enzymes will damage the vessel wall. Okay. So the prototype, as I told you, is systemic lupus erythematosus, and it is also seen in polyarthritis nodosa. Anti-neutrophilic cytoplasmic antibodies, right? So what they will do, it will be against the neutrophils, and it will lead to release of neutrophilic enzyme. There are two types of ANCA. One is PR3 ANCA, right? And PR3 ANCA is also called as C ANCA, right? And it is basically PR3 is neutrophil azurophilic granule. And so, the prototype vasculitis in which C ANCA or PR3 ANCA is present is granulomatosis and meningitis, which was previously called as Wagner's granulomatosis, right? And the second type of ANCA is MPO ANCA, which was previously called as P ANCA, right? And it is typically seen in MPO ANCA, is seen in Shrub-Strauss syndrome and microscopic polymyositis. So two diseases with MPO ANCA and one disease with PR3 ANCA. Okay. As I told you, drugs or microbial agents, it leads to ANCA formation, and once ANCA are formed, it will lead to a release of enzymes from neutrophils, and then the neutrophilic enzymes cause the damage. They are called as quasi-immune because they have no immune complexes. Anti-endothelial antibodies, the prototype disease is Kawasaki disease, right? And here antibodies are formed against endothelial cells, and so they damage the endothelial cells, and they cause thrombosis and ischemic infarction. Okay, so now with the background that the classification of vasculitis, that is large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. You know the pathogenesis of vasculitis, it can be immune complex mediated, it can be anti-associated, it can be anti-endothelial antibodies, right? So, and you already know the classification that which vasculitis comes under the category of large vessel, which vasculitis comes under the category of medium vessel, and which vasculitis comes under the category of small vessel. So, we will discuss these commoner types of vasculitis one by one. So, starting with giant cell arteritis, as I told you, this is called as temporal arteritis, and typically it occurs in patients uh, older than 50 years. So, in the clinical scenario in which the age is 40 or 30 or 20, it is not temporal arteritis. So the age has to be, because 95% of the cases, the patient age is above 50 years, right? It is a large vessel vasculitis. It affects the temporal artery, and then it will also affect the can also affect the ophthalmic artery, right? Pathogenesis is multifactorial. That is, antibodies are also involved. Anti-endothelial antibodies are also involved, and T-cell immune response is also involved, right? So, and then, as I told you about symptoms, the typical symptom is headache. Headache, number one. Number two, polymyalgia rheumatica, that is systemic symptoms, fever, fatigue, joint pain, right? And then, jaw claudication, that is painful mastication, right? And then the thing to worry is vision loss, that is the involvement of the ophthalmic artery. So what will you do if these symptoms are present? You will straight to do an ESR. ESR is raised, it means that this is temporal arteritis, and you can start treatment, or you can, in equivocal cases, you can do a temporal artery biopsy to confirm that it is a temporal arteritis. The biopsy shows granulomatous inflammation of the vessel wall, right? So there is intimal thickening, there is fragmentation of internal elastic lamina, and there would be granulomatous inflammation in the media, right? Okay, the second is, so this is one giant cell arteritis or temporal arteritis. The second is Takayasu arteritis. Takayasu arteritis generally occurs in younger individuals, less than 50 years. So a typical scenario would be an Asian female of age around 30 or 40, right? So temporal arteritis in males above 50, Takayasu arteritis in females below 50, right? Okay. As I told you, it affects the vessels which are originating from the heart of the aorta, right? So these vessels supply blood to the upper limbs, right? And so the pulse in the upper limb would be lost, right? And there would be difference in the blood pressure because both limbs are not affected equally, right? So there can be a difference in the blood pressure of about 10 millimeters of mercury if you measure the blood pressure in both arms, right? So these are the typical symptoms, and the thing